Second speaker is Steve Ryder. Steve Ryder is consultant hepatologist in Nottingham. He is the hepatology lead for the Clinical Research Network. He's done a lot of work in the Trent database. And Steve is going to tell us about what the implications and outcomes for what I like to think of as Greater London, but really is England, the area outside London, if we just carry on doing the same old thing that we're doing at the moment. So, Steve, implications and outcomes of current treatment rates are maintained.
Thank you, Ashley. And obviously, it's an absolute pleasure to work with HOMI to look at this model. And I know HOMI's already given away the key factor, which is that we can do something about this and we can get rid of hepatitis C. But I suppose what I'm going to do is just put a few of the challenges in doing that up. If you look at HOMI's bucket full of people with hepatitis C and the outlet and the input, you clearly have to address both of those in order to eradicate hepatitis C. You've got to stop people dying of the disease and you've got to stop new people getting infected. If you look at what we, in the Rumsfeldian tradition, the things we really know, we know, at the top here you can say, will we have improved treatments over the next few years between now and 2030? And I think the answer to that, anybody who's been to any of the sessions today knows, yes, is the answer to that. There is still clearly a bit of a question mark over whether we can afford them, which I'll leave at that, but certainly in terms of saying, will the drugs that we've got be able to give people better cure rates, fewer side effects, shorter treatment, and therefore increase the number of people who are eligible for treatment for their hepatitis C? Yes. I think the bottom things on here, in terms of increasing treatment rate, increasing the diagnosis rate, are areas where I think at the moment we'd be much less sure, and Matthew will talk a little bit more about that later. So what's the current situation in England? We treat about 4,500 people per annum, and we diagnose 5,600 new infections. So you can instantly see the tap is still not quite right there. There's more people getting this than are cured of it. Current cure rate, 70%, and we think 60% of people who are seen are eligible for treatment, whatever that may mean. Want it, can't have it because of the side effects, lots of other reasons. So if we assume that we've got better treatments, and those treatments will get better over time, you can see in the top, for example, 2013, where we are now, 70% of people cured with genotype 1. As you move over to 2018 and afterwards, we've seen these better treatments, we know we're going to be able to cure more people. So essentially that's the top bit of my first slide, which is we've got better treatments coming down the line. So if we leave everything else the same, treatment's going to get better, we'll cure a few more people and perhaps tip the balance there a little bit. We'll also see those treatments become more eligible to more people. So if you go to tablets rather than interferon injections, you can see you're getting up to higher and higher proportions of people will be suitable for treatment. But if we continue as we are, in terms of just treating the same people that we're seeing now, at that relatively small number of people, even with better drugs, yes, you see there's an impact. So if you look at out to 2030, we see the total number of hepatitis C cases, because we've switched that balance between tap in and tap out, gradually comes down. So you'd say, well, that's a success story if we do nothing at all. But, of course, that's only part of the story. Because all those people out there who've got significant liver disease, we're not treating all of those necessarily. And if you model what happens to people in terms of cancer cases, you can see this rather dramatic rise in numbers over 2030. So despite better treatment, we don't change anything else, we're still going to be looking after an awful lot more people with liver cancer in 2030. Liver-related deaths follow exactly the same sort of curve. So better treatments, but still not eradicating the disease in time for a lot of people to stop them dying of their hepatitis C. Decompensated cirrhosis, again, will continue to rise. So more people living out there with cirrhosis of the liver, maybe not symptoms yet. So I think we'd say, if you look at modelling the epidemic, you could say, well, actually, you know, we've probably reaching the peak, and you may be able to start bringing the numbers of people with hepatitis C down by 2030. But unless we change the other parameters on that first slide, we're going to struggle to actually address this liver-related mortality. Just to leave you with, in terms of the figures, these are the figures that come out of the model for 2030 if we don't do anything different. So 66,000 people living with liver fibrosis, nearly 15,000 with cirrhosis, 1,370 with decompensated cirrhosis, 920 liver cancers and 770 liver-related deaths in 2030. So unless we change the other inputs, we're still going to end up with a big set of problems. So the new drugs are only part of the equation, and we've got to think about how do we change service delivery in order to access more people to treat. And I think there are two key obvious targets in terms of new infections, which are people we know have got hepatitis C and are continuing to transmit it by injecting drug use, engage with substance misuse service, and in prisons. And I think we'd all agree at the moment that the standard of service provision across England for people in those two groups is pretty woeful. So we're going to have to do better at that. The second major challenge that we face is that 50% of the population with hepatitis C remains at the moment undiagnosed out there. Many people may have injected drugs at some point in the past, may have had a transfusion many years ago. They don't know they've got hepatitis C, and we've got this large cohort of people unaware, not perceiving themselves at risk. And unless we identify some of those and treat them, we're not going to change the direction of travel of that mortality and severe liver disease curve. I think I'm on time. Thank you very much.